And I think we should go ahead and get started. And as your colleagues join us, we will let them into the webinar. And we're also, as you know, recording this so that others will have the opportunity to access it. Well, thank you for joining us for this important webinar entitled Emerging Practice and Payment Models, Alternatives to Traditional Practice. I'm Susan D'Antoni, the CEO of Montgomery County Medical Society, and your facilitator for this evening. We are quite fortunate this evening to have knowledgeable and progressive MCMS members, three of them to present, and I'll do introductions of their speakers in just a moment. Beforehand, I wanted to remind you of some upcoming events that are going on in the Medical Society. So you'll notice that these after hours events, we have two of those here. And these we started about 2 years ago. They are hosted in physician member offices where there is a concentration of physician members in that area. So this is a very casual after hours, a few bites of beverage before people head home. And, you can often watch that, traffic out on 270 or 495 and then realize, well, wait, it's about time that I started that trek home. So that's the purpose, is networking and raising the visibility and awareness of these practices. And so we have two of those coming up. We also have a new member reception. If you're a new member, and new, we're very open about that. We define it as maybe a year to 2 years. You're still trying to figure out how to get the greatest value from your membership. We were going to do it in person. We've decided to make it a virtual event now on Wednesday, March the 18th. And so, we're trying to reduce the barriers and encourage connection and engagement with the medical society. So we thought that this might be a better way to do this, really to help you on your pathway, your journey to experiencing the full value of Montgomery County Medical Society membership and MedChi membership. Then also coming up is the installation of officers and annual meeting. This will be at Rock Creek Mansion, and we encourage you to come if you're an MCMS member. It is Wednesday, April the 29th, and this is our passing of the gavel. So for about an hour and a half, we have a reception, and then we will have our installation of officers, our annual meeting. And then I appreciate that there is going to be a reception that is following those activities to recognize my service to the Medical Society, as I will be rewiring on May 1st. So very much looking forward to seeing all of you, and really hope that you'll join us for these events. There are others that are being added as well. We're looking at another after hours on May the 7th. And then we usually start our summer off with an unwind event. And so we're looking at gringos and mariachis for that again. As long as the weather cooperates, it's an absolutely wonderful event for physicians to connect with each other. So as you may know, the Medical Society initiated a strategic plan this past year, and our theme is engage, connect, and empower. And that is why we're here this evening, is to engage with you, to connect with you, and you with each other, as well as to empower you to consider other models of practice, or to consider getting involved in the Medical Society, or consider being empowered to get involved in the legislative process. We all know that right now the Maryland legislature is in session. And they say, it's not pretty watching laws be made. It's like sausage, being made. And that is actually what's going on in Annapolis right now. But your Medical Society has been on Capitol Hill, as well as having our lobby day last week, so that we can carry your voice to our elected leaders. So we hope that you'll join us for any and all of these events. And so now I'd like to move on to the presentations. So it's my pleasure to introduce our speakers. I'm going to introduce all of our speakers at one time. We will have facilitated Q&A at the end of the presentations. Each presenter is going to speak approximately 15 to 20 minutes, and they're going to cover things such as how did you transition? Did you transition or did you start this way? What factors led to your alternative model? What concerns or goals influenced those decisions? What resources did you use? What steps were required? How did you structure the transition timeline? Did you have to restructure your practice to do what you wanted to do? How would you define your model? How would you define it differently than, say, a direct primary care from a concierge medicine practice? And what are those key differences? And so then we want our speakers to take us through in that 15 to 20 minutes about the operational aspects of it. How did you actually get from point A to point B? So first, we're very pleased to introduce Dr. Angela Marshall. Dr. Marshall is the founder of Comprehensive Women's Health. It's a primary care practice that offers both direct primary care and concierge medicine. She's board certified by the American College of Physicians, and I am thrilled to say that she is a past president of the Montgomery County Medical Society. I've had the privilege of working with Dr. Marshall as the executive director. And as you can see, I mean, she's impacted the lives of thousands of women, as well as being involved in other leadership roles, as well as having a social media and media presence. Our next speaker is Dr. Anu Dahiya. She is the founder of Elevate Concierge Medicine, which is a concierge practice. She's board certified in internal medicine with a strong interest in women's health. She obtained her Doctor of Medicine degree at the University of Massachusetts Medical School and is an active member of ACP. So with extensive experience in diagnosing and managing a wide range of medical conditions, she emphasizes patient education and empowerment in her practice. So we thank her for joining us. And then Dr. Serdar, MD, MPH, is a board certified internal medicine physician and founder of Bethesda Modern Primary Care. She trained at Yale, Northwestern, and UT Southwestern, and she brings nearly a decade of experience caring for critically ill and medically complex adults at Johns Hopkins Sibley, where she has also served in physician leadership roles. Drawing on her hospital medicine expertise, Dr. Serdar decided to specialize in preventive primary care, healthy aging, and menopause care. She is known for delivering unhurried, evidence-based medicine through her modern direct primary care model that prioritizes access, prevention, and long-term health outcomes. So we thank our three speakers for joining us. We are going to begin with Dr. Marshall, and we have a slide deck that we are going to share at this point. And so go ahead and do that for us, Farhana. There we are.
All right. Well, thank you so much,
Thank
Susan.
you.
Thank you for the warm introduction. And I want to thank MCMS for all of your support and advocacy over the years. And Susan, if it hadn't been for you and MCMS, I would have closed my doors a long time ago. So thank you for all your help and support throughout the years. So it's a pleasure to be here today to speak with you about some of the lessons learned in my 25 years of practice. I've been in private practice for 20 years. And as Susan mentioned, my practice is called Comprehensive Women's Health. It's an internal medicine practice for women. And I have to say that I know the title of this webinar is Emerging Practice Models, Concierge Medicine and Direct Primary Care. However, this is really about sustainability, access, and physician autonomy. And so I want to talk a little bit about my journey, and I've seen a lot in these past several years. And one of the things that I've noticed from my beginning even getting out of medical school, is that healthcare has been a constantly changing landscape. The healthcare reimbursement models have changed so much throughout my career. I remember when the HMOs were reimbursing at $10 per patient per month, to the modern day value-based care. And so one thing I've learned is that physicians are not necessarily trying to disrupt healthcare, but rather we are adapting to economic pressures that make traditional practice increasingly difficult. And so I have experienced that firsthand. As a primary care physician, I've seen the economics that have been so oppressive due to declining reimbursements, rising inflation, increasing administrative burdens, and large patient panels. And one of the things that I elected to do when I first started was to always value diversification of revenue, making sure that my revenue streams were diverse from insurance-based to private pay and so on. And so now diversification is becoming quite popular in defining the strategies of modern practice. And concierge medicine and direct primary care are two models that physicians are exploring in order to restore balance in clinical practice. And so today I'm just going to talk a little bit about concierge versus direct primary care, some hybrid models, which is what I elected to do. I also want to highlight some of the Maryland regulatory considerations because those are real and they can impact how we actually roll these models out, and then talk about the future of physician practice going forward. Next slide. Now, again, I mentioned all the changes in healthcare since I've been practicing. And unfortunately, they didn't teach business in medical school, which they should. And unfortunately, I did not have an MBA. However, I did have an undergraduate degree in engineering, and I used it to try to finagle and figure out all these changes and problems solved along the way. And so I really think that helped me to be able to survive all these years with all these changes in the whole healthcare reimbursement. And so one of the things that we've seen over the past several decades are declining reimbursements. And some of it may not be that the reimbursements really went down, but inflation has gone up so dramatically that effectively the reimbursements have, just become so minuscule compared to all the work that we do. In addition, we've had a rise in administrative burdens with documentation, coding, insurance denials, prior authorizations. We had several bills that we passed in the legislative branch around that, and just so many things that suck up physician time. And then also compliance, threats of audits and, fear that you're not going to code properly to get reimbursed and fear that they're going to come and claw your money back. I mean, it's just been a really hostile practice environment. And all these things have consumed increasing amounts of physician time. And also, because of all the reimbursement issues, the traditional primary care panels have swollen to 2,000 to 2,500 and beyond. And so some panels have been as high as 5,000 patients for one physician, making preventative and relationship-based care very, very difficult. And along with that has come physician burnout. I'm I'm a witness and in chronic burnout phase, but we've also experienced some workforce shortages, which has also been both of those things have been major drivers of change. And also patient expectations have been evolving. Now patients want texting access, they want telemedicine, virtual visits, and they want rapid responses. And so the patients have become more like consumers, which is sort of interesting when we've got third-party payers like insurance companies. But one of the key takeaways, I think, is that the real innovation in these models is not necessarily the payment structure, but the ability to care for a smaller and more manageable panel. And so I'd like to clarify a little bit about some of the differences between concierge medicine versus direct primary care. And so my story is when I started my practice, I started it as a traditional insurance based fee for service practice. And I had the fortune of being right next door to Dr. Julie Fox. And I don't know how many of you know Julie Fox. Julie Fox was, a leading physician in the area, is a leading physician in the area. And at the time I started my practice, she had just converted to concierge medicine. And she took her entire practice concierge. And I was literally steps away from her practice. And so, as her patients were deciding not to do concierge, we were scooping them all up. so, and so that was back in 2007. And a lot of the patients, they had a fear of us going concierge one day. And at that time, I said, absolutely not. I strongly believe in patient access. I will never go concierge. I'll always, be traditional. I'll never do that. Well, 10 years later, I went concierge. And so I'll talk a little bit more about that later. But I want to just clarify the differences between concierge medicine versus direct primary care. So, concierge medicine is a membership based program where you charge a membership and you still bill their insurance company. Now, because of some of the regulatory issues with that, when it comes to concierge medicine, that is one offering that I do recommend working with an expert partner with. I happen to work with special docs. But with concierge medicine, it allows us to have smaller patient panels, and many practices are choosing more of a hybrid model. And it also allows us to substantially reduce our practice size to like 400 to 600 as opposed to, 2,500 or so. And in some cases, I think as many, at one time I had like 6,000 patients. And so, it is just impossible to do that. And so direct primary care is also a membership model, but it operates entirely outside of insurance using a monthly membership model. And direct primary care practices typically include a defined set of services with very transparent prices. And so patients really love the transparent pricing. And so direct primary care is great for a lot of patients from that standpoint. Both models emphasize access, prevention, and really relationship based care. And I think that the reduced panel sizes really allow for physicians to coach their patients through their health journey with frequent touch points. I often say that it really does require time to deliver care. And, there's only so much you can do in a 10, 12-minute visit. And so these models allow us to spend more time with our patients, and it's a win-win for everyone. Next slide. Now, the emerging reality is that many offices are choosing a hybrid model. Now, when I started, the concierge practice partner that I chose, they were trying to convince me to take my entire practice concierge. And at the time, I had 9 providers. Many of them were nurse practitioners, PAs, and I had 3 physicians. And I just couldn't see it. And so I decided to do a hybrid model. So in this case, I'm referring to taking a few of the doctors concierge and leaving the remainder of the providers as traditional fee for service. And so in this case, we took 3 of the 9 of us concierge and then left the rest of the 6 in a traditional primary care model. And I'm so glad I did, because shortly after that, there were some economic headwinds that caused us to lose a few patients. And also our growth in the concierge membership, although it was really good, it wasn't as strong, or wasn't strong enough to be able to carried 9 providers. And so I was so glad that I kept that traditional model as our base revenue, because additionally, the increase in membership revenue was not enough to offset what we lost in the volume. And so it was great that we had the other providers there that capture all the patients that chose not to go concierge. And so I thought it was a great decision, and I'm glad that I didn't listen to the partner that tried to have us all go that way. Also, I wanted to share that there are all types of different hybrid models. There's concierge membership, there's traditional insurance, there's direct pay services, and then there's also direct primary care. And so I also wanted to just explain the difference between direct primary care versus direct pay services. Direct primary care is more of a membership that patients pay when they may not have insurance, or they may have a high deductible plan, whereas direct pay services are for patients who have insurance, but they pay cash and then they get reimbursed from the insurance company instead of the doctor billing the insurance company and getting reimbursed directly. And so we started the concierge practice in 2023. And shortly after that was the election. And the current administration won, and a lot of federal workers lost their jobs. And so when the federal workers lost their jobs, we thought, well, we should offer a direct pay model, a direct primary care model as well for those people who no longer had health insurance. And that was really helpful. We only charged $150 a month for all-inclusive primary care. And we had a special deal with LabCorp, who offered self-billed labs. And so we were able to do like traditional physical labs for about $50 additional. And so it really was helpful for the patients. And so one of the things that I feel we've been successful in doing is being able to really bolster our revenue while still maintaining good access for our patients, and offering enough options for our patients so they didn't feel abandoned. And we also were able to help patients in their time of need when they lost their health insurance. Next slide. So one of the things that I strongly believe in is when you do decide to have a practice offering, design it as a signature offering. Think about ways to brand it, ways to package it. You can think about adding tiers to it. One thing that I've learned is, just like in business, patients are consumers, and they love to know what they're getting for their money. And so making it really clear, we had very clear advertising, very clear delineation on our website, what was offered in each tier, what was offered, what the pricing was, and things like that. And patients really loved it. We also offered a weight loss program. And so one of the things that we did is we used our name, Comprehensive, and just kind of carried that through all of our offerings. So we had comprehensive concierge care, comprehensive weight loss, and then we had a MediSpa component as well, just for the additional stream. And then we also offer comprehensive basic care for our direct pay model. And so again, being able to brand it, package, and then also bundle services. So being able to add other offerings like ancillary offerings, laboratory, even retail products. And some people are now doing some of the IV therapies and things. And so there's all sorts of things that you can add. But thinking about how you would bundle those services and how you would also charge for them. Now, I will also say that it's important to think about different technology platforms that you will use for these offerings as well, because The traditional electronic health records, they didn't offer things like subscriptions or, regular recurring, they call it MRR, monthly recurring revenue. Whereas monthly recurring revenue, I learned that's a way to really add value to your business. If you've got a strong monthly recurring revenue that's coming into your business, that's a way to really add value. And so having a platform, we use Square for that, which was outside of our EHR. So it's important to be clever with the type of technology you use as well when you're building these models. Next slide. And so it's difficult to talk about these different models without talking about the unique regulatory challenges in Maryland. So Maryland is one of the most regulated states for physicians. And I just learned this not long ago, that Maryland has a mini Stark on top of the Stark laws that are at the federal level. And so Maryland physicians operate within 3 regulatory frameworks. We have the federal Stark laws, which really governs self-referral for Medicare services. And so I always thought we only had to worry about the Medicare patients. Well, in Maryland, you have to worry about everybody, even the commercial payers. And so, of course, we all know about the anti-kickbacks and prohibition of financial inducements for referrals. But the Maryland patient referral law also applies. And that applies to commercial payers as well. So I encourage you all to become very familiar with all the Stark laws and the mini Stark laws, particularly that pertain to Maryland. Additionally, Maryland has fee splitting restrictions. They have MSO management fee scrutiny and ancillary services related to ownership. So if you have another business, for example, that you're referring patients to for something, that sometimes can get more scrutiny and can get you into trouble. Whereas if services are offered under your one umbrella, your practice, there's less issues with that. And so I don't want to go into all the details here today, but I just wanted to raise the flag that this is something if you're thinking about multiple different models, certainly familiarize yourself with all these regulatory considerations. Next slide. And so I think the physician practice landscape is continuing to evolve. And I think it's continuing to evolve to a multi-model ecosystem. And so there are 3 emerging lanes that I see happening: the large health systems and integrated networks, and then the concierge and membership practices and direct pay digital care models. And so one of the things that happened in the Big Beautiful Bill is there are going to be some changes to how patients pay for care. For example, there are going to be more health savings accounts, whereas in the past, HSAs have been tightly tied to your health insurance plan. Whereas with the Big Beautiful Bill, some of that has been decoupled or uncoupled, so that patients may be able to more freely have health savings accounts so that they can be more in charge of how they spend their healthcare dollars, which will really benefit concierge medicine and direct pay model. And if you look at the compound annual growth rate for concierge medicine, it's expected to continue to grow at a rate of over 10% a year between now and the year 2033. So I think if you're thinking about concierge medicine, now is a good time to do it, because it looks as if we are going to be moving more in that direction, both concierge medicine, direct pay, subscription-based, and less reliance on the traditional insurance-based fee-for-service. And also, again, last thing I'll say is I want to highlight the importance of using smart technology, telemedicine, remote monitoring, AI documentation tools. All of these may make these models a little bit more economically sustainable. And I will close with the idea that I believe that many of these models will help us to restore time, restore relationships with our patients and our families, and allow us to practice better medicine overall. So thanks so much.
Thank you so much, Dr. Marshall, for those insights, that excellent information. Really appreciate. I definitely learned things. So, about the differences in each of the models and how you can kind of do add-ons. So that's very interesting. So our next speaker also is an expert now because you had to kind of immerse yourself into it. And so why don't you go on, Dr. Diha, please?
Okay. Thank you, Susan. Thank you so much. And thank you to MCPS for allowing us to kind of help our fellow colleagues figure out their way through all of this. My talk is going to be very informal. I just want to say it from the heart. I was also, by the way, an engineering major, Dr. Marshall. So I did electrical
Interesting.
engineering before I went to medical school. So yeah.
It's electrical, electrical
Maybe,
too. Yeah,
oh,
we'll
maybe
have to talk
something
about
about us
that
engineers. I don't know. I
for
don't know.
sure.
Um, but when I first started out, I graduated from University of Massachusetts and then went on to Albany Medical Center. From my husband had his residency that he was doing there, so I got pulled over there. So I was there for 2 years after I graduated because his was a 5-year program, mine was a 2-year program, and I worked as a hospitalist, as a teaching hospitalist for 2 years in that area. And then I got bamboozled into going to Toronto for a year for his fellowship. So then I ended up not being able to practice in Canada. So I had to actually commute 80 miles 2 to 3 times a week and work in ER in Niagara, New York. So I got a lot of expertise during that 1 year when I was working in Niagara, New York. And then I came here and didn't really know anyone, didn't really know the system, and applied to Kaiser because it was a big organization and I thought they'd probably have jobs for starting out physicians. And sure enough, I worked as a hospitalist for Kaiser for about 2 years and then decided that I really needed a more set schedule. And I worked as a primary care for them for the next 18 years. Um, the reason why, and some people say, like, why did you decide after 20 years to leave? Like, what was the incentive? I think there were a couple of things. I think, first of all, there were a couple of things that kept me at Kaiser. One was that I didn't have to take any call at nights. I didn't have to do weekend call. It was great with children. I worked 3 days a week on my own clinic, and then I worked 1 day a week teaching at the residence at Kaiser. We have actually a residency program in internal medicine at Kaiser. So I was able to teach the residents on Fridays, which I just absolutely love to do, and it was a great experience. So I didn't want to leave because I loved my patients, had 3 days of clinic, and then had this one teaching day, and it just seemed like it was a good package for me. I think I decided to finally leave after the pandemic happened because a lot of physicians at that time either retired or they decided to just leave medicine altogether. They just left. I mean, we literally had, out of 18 of us, 8 of us leave the system at that time. And so after that, we just kept thinking things would get better and we would get more physicians to help us. But my panel size grew to like 154% of what at Kaiser, 110 to 120 is normal for a physician, but it grew to 154 and nobody would do anything about it. And obviously, patients that were mine, they wanted to stay with me and wanted to continue their care with me, but then new patients got added on because we didn't have enough clinicians. So it just got to be really daunting. I just felt like I was just basically seeing people every 15 minutes, not able to spend time with them. so many quality measures, so many billing issues. Even as a Kaiser physician, we have to bill Medicare and so on and so forth. So all those refresh diagnoses, there was just a lot. So anyway, I decided to leave finally. And the reason why I didn't leave for so long is because I was scared. I was scared. I was scared of starting something on my own. It's scary. You just think I'm gonna be with like I'm gonna start with zero patients, and how am I gonna make this happen? And um, I literally left Kaiser with zero patients because nobody could leave the Kaiser system. They all had their connections and their specialists, and so I left. And plus, there's a caveat that when you leave Kaiser, you can't take any of your patients with you. So I didn't even try, and I left, and I started my practice with zero patients. Um,
Mm.
I the reason why I decided to go the concierge model, and I actually didn't, the way my concierge practice works is I do not bill the insurance companies at all. Okay. There's a membership fee to be part of my practice. 30% of your reimbursement, your resources do come from billing an insurance company, but I did not want to deal with, I was so done with billing for insurance companies and dealing with any of that. So I said, you know what, I'm going to take the hit. I'm not gonna ask for the 30% from, different insurance companies. I got a lawyer to help me opt out of Medicare. So I opted, you can actually opt out of Medicare. The thing about the caveat about opting out of Medicare is you have to do it every 2 years. You have to do it on time. You have to opt out of Medicare or you're pulled back in. So I opted out of Medicare, which basically meant that, um, I my patients that joined me that were Medicare patients could not provide a super bill to Medicare to get reimbursement for their care. Or the Medicare patients just had to pay me the 2,200 to start with me in the practice, and that was all I basically charged. Um, I think one of the important things to keep in mind when you're doing any of this is plan a business plan, create a model for yourself. Now I could have there was special docs, there was some other companies that you can go with that her medicine that help you establish yourself. But I sort of just felt like, even if I'm, like 2 years out with 100, 150, 200 patients, like I'm going to be okay with that. Like that's all right with that, for me. So one of the most important things I want to tell you guys is make sure that you have somebody that's, you're using a good EMR system. It's critical. You have to have a good EMR system. A lot of the EMRs do the billing for you. They also do the linking for you. So now remember, I came out of Kaiser. I don't know a single physician outside in the real world. Okay. So it's, I mean, even today, like for me now, I've been out for like a year and a half. It's still daunting to like come up with the right clinicians. And that's where MS has really helped me is I've met other clinicians that can really be helpful to me, and I can be like, okay, I'm going to refer a patient to you. You seem wonderful. Um, but that was the other fear of coming out of Kaiser was who am I going to refer to? I don't know anybody. I don't know anybody in the system. I know all the Kaiser physicians for the last 20 years. Um, the EMR is extremely helpful because I started out with an EMR that I didn't love, and I quickly shifted immediately to an EMR called Elation that I really liked. I think Athena is really good too. And the reason why it's important is because when you're doing referrals, when you're doing consults, when you're doing orders for radiology or anything like that, you have to be able to make this a very seamless thing, okay? And so, you have to know which place the patient wants to go to, and it needs to be quick and easy, and you need to be able to refer out to them. So be very thoughtful about your EMR. It makes a world of difference. It's really important. I also had gotten McKesson to do my examining room and set up my examining room, and then I did my own office. I just kind of got little pieces of furniture and things and pulled it together. Um, I will say one really lucky thing for me that I can't, I know this is a big hit for a lot of physicians that are going out on their own. I have a spouse who is a facial plastic surgeon, so he was on the first floor of this office building that he had in Rockville, and his second floor was completely empty, and he wasn't utilizing it. So I was like, well, I can pay you rent, let me come on board. And so that's the way we're working right now. I'm working upstairs and he's working downstairs, and it's worked really well for the two of us. Um, Starting out with zero patients is really scary. You just don't know, like, how are you going to manage it? What protocol you're going to use? I think having personally for me, having somebody work with me from the very beginning, I had an MA that was a receptionist, that was my office manager kind of person that I hired after, really investigating and looking around. Um, Somebody who was reliable. And I've kept that person, happy for the last year and a half that she's there, and just made sure that we work together. And it's really nice. She, can answer my phones, and she can, she's an MA, so she can draw blood. So there's like multiple purposes that I can use her for, which has really been wonderful. Um, so, advertising, how did I get the patients that I have now? So I started out with advertising in some local newspapers and local like magazines like Kentlands and Avenel, and a couple of other local magazines I advertised in. I made sure that when a patient saw me, that they got to spend quality time with me, so that if they would refer their husband to me, or their family member, like, that was really helpful. But I'll tell you, there's a market out there for concierge medicine. There really is. And um like, it hasn't been that daunting to grow. Like, people are looking for a good primary care doctor that cares, and somebody who's going to listen to them, and somebody who's going to really try to help them. And I think I got a lot of training when I was at Kaiser. It was 20 years of lots and lots of training. So I got to see it all. So I wasn't scared when I came out in that sense. Like, I knew I was a good clinician. I knew I could make it. I knew I had the ability to do it. It was just, how was I going to manage all the different parts of my practice? And I'm not a business person. So, but I'm good with numbers, so I can, kind of pull it together. Um, so that has been my model. Like I said, really didn't want to deal with insurance companies. I called it a day. I said, I'm going to take a little bit less. I'm going to take a hit, but I'm going to just, charge my fee to being part of my practice, my membership fee, and that was all that I was going to do. And that's really been really good for me. Um, the hardest part for me is the networking, because I'm 50 and I don't feel like going to everything, It's like I'm like, oh God, I have to go to a networking event. But it's also really nice, all the people that I have met, and the clinicians that I've met, and the friends that I've made. I mean, I've made some really good friends by networking. And I will also tell you guys another thing. The clinicians that are out there that are doing primary care on their own, that are concierge, were so welcoming to me. They were so warm, and they were like, "What is it you need? How can we help you?" Yes, we're willing to meet. Yes, we're willing to introduce you to people, like, what, and I think that is the collegiality I think that we're all striving for, and we all want so desperately. And everyone has been so wonderful. So if anybody ever needs anything, like, I'm absolutely here to help you. Um, and it's been a journey, but it's been amazing, amazing. I'm like so happy with what I'm doing. I go into work every day, like, thrilled. Of course, I don't have the number of patients that Dr. Marshall has or somebody else has, but I go in with a mindset that, like, I'm gonna see patients, and they're gonna get to spend some time with me. I'm really gonna get to know their families and their lives, and it's been really, really wonderful. So if anybody needs any kind of assistance, help, and they just want to talk it out, like I'm happy to help. So that's my take on it.
Thank you so much. I just put a note in chat. I think we need you to be a mentor in our new physician peer partners program. All of you. That would be great because certainly we have physicians who are contacting us regularly, wanting to know who to talk with. And so that's one reason that we set this up. It's very easy to enroll. And then we just match you with physicians who then, request a mentor. No cost. It's all part of the Medical Society experience. And so we'd really appreciate your involvement in that. All right, so we are going to switch gears just a little bit, and we welcome Dr. Serdar with Bethesda Modern Primary Care. And so please share your experience with us.
Sure. Thank you so much for having me. Dr. Marshall and Dr. Dahia, thank you so much for what you've offered. I think I echo kind of what you're saying, where I like the message about diversifying and sort of making sure that your income stream is not dependent on only one factor. And then Dr. Dahia, I like that. I am sort of, it has been true for me as well, that anybody I've asked for help or anybody I've asked for guidance, for the most part, people have been extremely helpful, to the point where I'm like, I kind of feel bad because I don't want to take their time, but it honestly has been really, it's very generous. And I think there's a sense of like when you're winning and we're winning together type of thing. There's like no shortage of patience, and there's no sort of, even if you're like just down the road from each other, it's not like this typical business model of like competition, like Target versus Walmart. It's just not. It's not the same thing. And you don't feel it, and you definitely don't see it in practice. So I'm going to try to be a little bit quick because I don't want to take too much time. Some of this I think we've already covered. So if we go to the next slide. Just a little bit about my background. I did public health, global public health before I went to medicine. So I practiced in Zambia, Zimbabwe, Ethiopia, and different parts of President's Emergency Plan for AIDS Relief, PEPFAR. So it kind of makes me sound old, but it used to be cool. And we did global public health, and I did that for quite some time. And then I went back to medical school at the age of 27. So American Board of Internal Medicine certified. I actually pursued a fellowship in infectious disease at Georgetown. That's what brought me to DC. And I didn't love it. So 1 year through the fellowship, I was like, this is not for me. And I took the hospitalist position kind of on a whim because I thought I'll just figure things out. And then lo and behold, like COVID happened and third baby happened. And 9 years later, I was like, oh my gosh, I can't believe I've been here almost a decade. So the reason that I left wasn't because anything was really bad per se, but I mean, I really miss the people I worked with because they're awesome, and I'm still on sort of staff there. But I just kind of looked in the mirror and thought, okay, I could literally do this for the next 30 years, but am I really happy or am I just like coasting? And so it was a little bit of an existential crisis because I thought I could just keep going the way it is and it's easy and fine. And I almost go on autopilot. But I just thought if I really want to try something, now's the time. And it's okay if I fail. And I know that's a really scary thing to say out loud, but you have to try, otherwise you'll never know, right? So there was a lot of like mindset work that happened, and I'm going to go through kind of what I thought was really helpful to kind of get myself in a place mentally where I could navigate all the different hats that you have to wear. Next slide. So this is sort of like just inpatient hospital medicine is what I did at Sibley. Everybody was very, very sick. In the beginning, we had a few wins here and there, but by the end, I was doing hospice and palliative care 3 days a week. I mean, 3, 4 times in the week, I would be like explaining to someone who I've met 5 minutes before that your loved one is going, and I'm sorry, and how do you want them to go? And, really, really, really sick patients. And so on the medical part, it was really, good training. I mean, I'm really comfortable with really sick patients, but I sort of didn't feel like I was quote unquote like making a difference or able to even get any wins. And I would say sometimes hospice was a win, but that's just not the medicine I signed up to do. So essentially after, several years of that, it became more and more apparent to me that it was not feeding like my initial like purpose and my mission. Next slide. I wanted the deeper relationship. The, maximum time as a hospitalist you get, if you're lucky, is 2, 3 days max. I would often get questions like, can you be my primary when I leave here? And it would break my heart because I would say like, I'm so sorry, I can't, I'm not allowed to. And that felt weird. Like, I'm a doctor. Why can't I take care of who I want to? But it was just normal and obvious that, okay, hospitalists, they own you and that's it. Um, I also felt really bad about a lot of the things I saw that were so preventable and not like rocket science, like very, very preventable. Can we pull them out of the water earlier? Just because of the lack of knowledge and these people were insured, they had access, they're not really disadvantaged. I mean, you have a little bit, but really these people are super like all stretches of the imagination empowered. And yet still the delivery of healthcare was missing from the prevention standpoint, and they come in with end stage disease that I thought was preventable. And then I also do really feel strongly about healthy aging in the sense that I think we have our boomers and sort of my mom's age group and above are hanging out and sticking around for a long time, and it's about quality over quantity. And I wanted to help with that journey. Next slide. Goals for the new practice we talked about: offer longer visits, prevent disease earlier, improve physician accessibility. One part that I got really excited about, it's kind of a circular story, but when I was getting ready, my mentor in medical school was OB-GYN, and I was getting ready to apply for residency, and I was hell bent on OB-GYN like the whole way through. And then at the 11th hour, he was like, Nadia, I know you really want a family, and just look around you and look at the faculty here. Like, do you think that this is the lifestyle you want in 20 years, 30 years? And so last minute, I applied to internal medicine, and I loved internal medicine. But now, come full circle, I'm obsessed with women's health. And I think it's so much fun and so interesting and new and different. And it's complicated, but like in a good way where you can integrate it with all the other systems in primary care. So that's something that I really wanted to do for my new practice. Next slide, please. Membership-based primary care, you guys got the message on this. It's you pay a fee, either annual. For me, it's annual, semi-annual, or quarterly. A lot of the practices around the country differ. You can do monthly, no insurance billing. So I don't do anything with insurance whatsoever. For me, the reason for that was that I just don't have the capacity. So I'm one person, it's the micro practice. Who's going to be my person to do all that? So instead of trying to navigate how to figure that out, I just decided to opt out from the beginning. Next slide. The membership model is, for me, includes the annual exam with the Well Women's exam. So I do the pap smear if people need it, and 5 additional visits. And then at the moment, I have unlimited direct access from 9 to 4, Monday to Thursday. And here's the kind of like key point. I always tell my patients when I'm onboarding or doing the discovery call, I'm one person, you need me to be awake and like alert and like oriented. Like, it's just not going to happen if I'm up all night. So I do see in my practice, if I can get all the answers and if I can give good care during business hours, I really haven't gotten that many calls after hours, to be honest. And if I have, it's never been after like 9. I was terrified of being like deluge of like calls. I don't know why, because at Sibley, as a hospitalist, I was running away from patients, and here I'm running towards them. And it was so weird. It was like such a weird mindset shift where I want to make sure they're okay, but I don't want to overstep and not have boundaries, because then it's not sustainable for me to be able to give that sort of like, anyway, long story. I think this is very sustainable and doable. You just have to set expectations early and be really honest with yourself, and your patients. And you might feel bad to say no, but it's better to start with no and then decide later. Next slide. My membership model, there is like the math has to math. So the real estate in this area is extremely, extremely expensive. And so I have decided early on, I have 3 kids in school. They're at like Pyle, Bannockburn, and Chevy Chase. So I need to be within 10 minutes drive of my children. That's been a priority. My husband's a stroke physician, and he's a great dad, but he is always on call. So I thought I have to physically be here. That means the rent is going to be this much. And so the membership for us is about $2,500 annually. If people want some sort of flexibility, we do $1,500 biannually or $750 quarterly. And I think that's a number that I have to keep looking at based on what's going on with like inflation, number of patients I have, like whatever. But the point is, just as like a kind of a joke, kind of not, I chat GPT'd how much people spend in Bethesda on hair and nails, and it's a lot more than this. So next slide. Insurance billing versus membership. I think you guys know this part. High volume versus smaller volume. I don't know what my magical number is at the moment. I think our generally the goal is typically like between 3 and 500, maybe 400 is a sweet spot, but it really depends on who joins the practice and how much they need me. I'd rather have less patients and give the quality care than have it suffer and then have people say, well, you were great, but now I really don't see the same kind of doctor that I had when I started. So that's kind of the goal. Next slide. This is something that I think is super important. So the Montgomery County Medical Society has been amazing. Erica Wing was one of the first people that introduced me to you all, and I started coming when I was still a hospitalist. I came to your Red event, I think last year or the year before, and it was just so fascinating to me because in medicine, in hospital medicine, we are very like bonded and get along, and everything's great, but we don't really, see each other outside of work. Whereas this was like people are getting coffee, they're going on walks, they're like networking. So it was really cool to see the difference in like real life type of networking versus just like we're here together in the same place. So I think that was very important because when I was doubting myself, a lot of physicians out on their own medicine, either internal medicine or subspecialties kept saying you can totally do it. The practice website, I think that one thing I've learned that's really important is your online presence is equally important, if not more, than your actual real life presence. Because everybody's living online, that has to be something that you become comfortable with and or find someone who's really comfortable with it. I didn't care about fonts and I didn't care about colors and I didn't care about logos. And these are things I had to learn on my own. And it was like really mind numbing to be like, I don't know which font to pick. I don't care. But it really doesn't matter how something is presented. And it's good to find people that can help you. And so I was able to find someone that was very reasonably priced and was very helpful, but it was just a lot of man hours to come up with our website. The patient education for social media. So I'm just going to put a plug in here. I would not have said a year ago that I'm like a convert. Like I would say, stay away from social media. It's weird. It's salesy. It's gimmicky. There's a lot of misinformation. But now I feel that there is a moral obligation in some sense for us to show up where our patients are. Because if they are consuming information that is incorrect or dangerous, there needs to be some voice there that's saying like, actually, I have like a medical degree, a residency, and 20 years experience, and this is what I will say is correct and not correct. So having said that, doing a 40-second reel is no small feat and it takes a lot of time and energy. So I know some people will ask for companies to do this for them. I would suggest not doing that in the beginning because you need to find your voice and you need to make sure you're authentic. Because human beings are good about picking up on when you're sincere or not. And I think if there's someone else's voice, they can tell like between that voice and the one that they meet. Next slide. Website enrollment. So I just set up the website, like you were saying, Dr. Marshall, where you have like a kind of a funnel where you go on the website, you put in like, I want to do a discovery call. Then I booked the discovery call. My first mistake was allowing people to come in person. Don't do that. People will come in person and take your time and energy and then not sign up. So it's like you can achieve better volume if you do things on Zoom, and people are pretty reasonable about doing Zoom. In the beginning, I gave 30 minutes, then I gave 20 minutes. Now I can tell in 15 minutes if it's a go or not. And what I always do is have like a list of doctors that I want to refer to if I don't think it's a good match for me. Obviously, asking those doctors like permission, what kind of patients do you want? Because it's really helpful for people to say like, yeah, I didn't find that it was exactly my fit, but this other person down the road is a great fit. And that breeds not just collegiality, but like kind of like a full 360 of like when that happens to them, they can refer someone to you as well. Onboarding is 3 main forms. I'm almost done, my love. 3 main forms, all the typical like release of medical information, blah, 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 blah. That's one email and the patient agreement. And then that was with an attorney that I think most of us have used. What's his last name? Pecor? Pecor, he's like the one that everyone kept telling us to use. So he was great. Next step, next slide. Okay, so community outreach, I'm a little weird and I show up in random places. So I Love the farmers market. I've always gone since I was a kid. And so I tried to figure out who was the Bethesda farmers market person. And I went and talked to him. His name is Mitch. He's like 88 years old. He likes to swim. He wants you to show his muscles. Like he's just the most sweetest, kindest human. And he wanted me to like come with a table. So I paid, I think like 800 for the year and I set up a table. And I'm going to be honest, the first time, second time, third time I did it was really, maybe first time was really awkward because,
Mhm.
you just, it's scary to put yourself out there and like you're a doctor and you're not used to it. Like you're not used to being like with the people. And it's so weird. My mom, I actually was not brave enough. I asked my mom, my sister, my brother-in-law, my children, my husband. Like I made everyone come with me. And some of
Mhm.
the patients who signed up are like, "Oh my gosh, your 6-year-old nephew was like primary care." Like it was like a family effort. And it sounds silly, but they made me brave.
Mm,
And I did
that's
it
awesome.
anyway, right? So
Mhm.
but you don't have to go to the farmer's market, but wherever it is that your community
Mhm.
is, just go to them if you can.
Mhm.
Next slide. I think the education piece has been big. In the beginning, I got really discouraged because people sometimes get mad. They're like, why are you doing it this way? I'm not happy, especially the older folks. Like a lot of the folks getting discharged from Sibley, my hospitalist colleagues would refer me. I talk to them and they'd be like, you don't take Medicare? Why? What's going on? Not happy. So that piece, you have to have a little bit of thicker skin.
Mhm.
Even if you explain it to them, there's people who want to do this and people who don't. Membership pricing, same story, be very transparent. Don't feel bad. Figure out what your why is and what you're comfortable with and just go for it. People will understand your value only if you see your value. And then the initial patient panel, I had the ribbon cutting on January 9th. It's like very slow and steady, but it's okay because I think that's kind of like the way it is for micro practice. And I think you get better patients that way when it's organic. Like someone says, "Oh, so and so has told me about you at my yoga thing or at my library thing." And it's really nice because then people start saying, "I think I've heard your name before," or "I think you were at the farmers market." And it feels very, very hyper local, but that's the point. This is sort of like direct primary care is supposed to be like kind of like a niche for community. Next slide. Love the time with my patients. I focus a lot on prevention. There's a lot that they're going to tell you if they feel comfortable with you. Everyone knows that. Next slide. Um, be really clear about your mission. Be really good about educating the patients. Practice your elevator pitch on everybody, your neighbors, your friends, the guy at the checkout at grocery store. My kids are totally embarrassed because they're like, "Mom, you tell everyone I'm a direct primary care." My now 6-year-old was like, "I don't know about perimenopause, mommy." And I'm like, "Okay, well, we haven't even done the birds and the bees, but you're talking about perimenopause." So, like, it's okay to include everyone you love because I think it helps you stay like focused. And I think it keeps you honest that you said you were going to do it, and this will kind of like help you keep going. I'm at the very beginning, so I'm sort of on the other end of the spectrum from you, Dr. Marshall, where hopefully in 20 years I can say this was like very doable, but right now I'm really like bootstrapping it. Next slide. That's my website. I really love it. The colors and the logo. Everything is homemade. So that logo is a 15-year-old at Whitman, is the daughter of my website designer. She kind of scribbled it out and I loved it. The text is all stuff that I wrote myself. And I do Instagram and Facebook as well. I just do the one thing and then I just like cross post. But really, I have found a practice manager who could help me do the social media piece because I can't see patients and do that. It's too much. I have two virtual employees. One is like a nurse type, like MA, and she does all the like before I see the patient, all the stuff that goes into the chart and helping with like calling people back, etc. And then the other person is more of my social media person and like operational. And she's like 20 years younger than me and very smart. So I lucked out with a good person, but I also think staying humble and like being okay with learning everything from scratch is probably a good way of going about things because you know, I don't know. I think it's hard. It's hard to start over in something new and be like, I don't know what this is. The first time I heard what a CRM was, I had no idea, and everyone else knew what they were talking about, and I didn't. But it's not a big deal. You just learn about it, right? Next slide. Um, I started listening to these podcasts about 18 months before, and I really love them. There's EntreMD podcast I liked. DPC Life was really wonderful. My DPC Story is my favorite. And then I just started listening to Kara Pepper. It's just like voices that sound like one of your friends or one of your colleagues, and they are literally feeling and thinking exactly what you're thinking, but then they help you like navigate out of certain problems, and it's just nice to hear from them. The books I really like: 10x is easier than 2x, Positive Intelligence, blah blah blah. So these are all the long list of books. I haven't read every single one, but I can tell you I have like done like speed reading on a lot of them. Very helpful. I was sort of like, I don't need cheesy self-help, but these are not self-help, they're kind of practical. And it's very helpful to have different, um, kind of like how in medicine you have cardiology, pulmonary, rheum, like everyone has their niche, and it's nice to see how different people look at the same thing. Next slide. These are the E-Myth. I actually do recommend reading. It's a little depressing in the beginning because he talks about how most things fail, but he kind of moves on from there and kind of helps you figure out like what you need to do. Eat That Frog is hilarious, but it's like we never want to do what we don't feel comfortable with. And the idea is for us to start with what we're uncomfortable with because it's more likely that you're going to do it. And then Soundtracks I haven't read yet. I think that might be it. Oh, okay. And then the DPC Alliance, I went to their meeting last July in New Orleans. I don't know if you guys know how horrible New Orleans is in July, but they got a good deal and we got a week in the hotel, super hot. But honestly, it was a wonderful thing to attend because there were these people called DPC Curious, like those folks that were kind of thinking about DPC, not sure what they're going to do, like kind of putting their toe in the water. And then there are people who are full on converts who have very successful DPCs, like in whatever part of the country they're in. And similar to the Montgomery County Medical Society, people were very helpful and very generous. And I made two very good friends then. We keep like checking in on each other. One is starting the same time as me for peds, and one is established for 8 years in adult DPC in Miami. So we upstate New York, Miami, and I'm in DC. So different markets, but helpful. And I think, is that it? That's my contact information. If you guys want to follow me, you're welcome to. I'm always up for a Zoom or connecting with anybody who needs advice. I'm going to respectfully decline being a mentor because I just started and I want to know a little more before I tell other people. But yeah, no, this has been a lovely experience, and I'm so grateful that this opportunity even exists because I'm not sure how long I was going to stay in medicine if I didn't have this option. Thank you.
Well, thanks so much. I mean, that is just so insightful. I mean, each one of you are at a different point in this journey. And so it's really incredible to hear from each of you. And I'm glad that we recorded this because I'm sure that there are going to be a lot of other physicians that are very curious, the DPC curious, and very interested in what it is that you're doing. And so we do have a specific question directed at you, Dr. Serdar. How many patients do you have at this point? Do patients have your cell phone number for evenings or weekend calls? And the rest of you could also
Yeah.
respond
So
to that second point.
Right. So one thing I should put a caveat, I've been talking about doing my own practice amongst my close like friends and community here for about 3, 4 years. So before I started, I had 15 people who were just waiting for me. And that's a wonderful feeling. And you don't kind of believe them until it actually happens. But so I started with 15, which was really helpful. And then at the moment, I'm at 36. So about 2 or 3 per week, maybe.
Mhm.
I think average is maybe less than 5 a month, but I've only been open since January 9th. And you asked me a question about cell phone. No, they do not have my cell phone. I have a CRM, and that number means you can text, you can call, you can direct message. Everything goes through that. And I respond through that as well. Sometimes it's a pain because you have to use the app, but I think that's better. It's just hits a boundary for me.
Mhm. And what about the others of you? How do you handle that communication with
Yeah.
patients?
So I use a phone app. It's called Ring Central. That's our phone system. And so the patients have my number on there, but it actually rings to my cell phone so that when I'm on vacation, I can forward that number to my partner and they're not calling my actual cell phone. So I highly recommend keeping those separate. But in terms of how many calls I get, I hardly One of my fears was in going to concierge medicine was that people were going to call me all the time. I hardly ever get called after hours, like ever. People call during hours and they call my concierge receptionist. And sometimes they'll call my cell phone, during office hours, but I never, now watch, I'm going to get called tonight, but
I'm
I
going to call
never,
you. No, I'm just kidding.
I never get called after hours. I just don't. It just doesn't happen. Now, sometimes, yeah, I just don't. I hardly ever, which is surprising.
Yeah, I mean, I thought the same thing. So I do give patients my cell phone, my personal cell phone. I thought that, I was going to get barraged by text messages and people calling me. They do not. They do so the best way to communicate with me is through my portal. My portal is pretty very user friendly and people can use that and send me messages and I respond within a few hours because what happens is my cell phone will say, "Oh, patient's left a message for you." So I'm aware, so I can go in at any time and look at that. Um, I do give my cell phone for emergencies, I tell patients, like if it's really an issue and you've, passed out or, you've got the flu or something, just go ahead and give me a call. But people don't, they just don't abuse it. They just don't.
Mhm.
And it's been great. I mean, I've given my cell phone to every single patient that's walked in my door, and
Hmm.
nobody has abused it so far.
Mm.
So, how long are each of your visits? And is there a direct correlation, do you think, between how long you spend with those patients and then how much they call you after hours? I mean, because the average physician visit is about 7 minutes long in traditional practice. And so, if
Mhm.
you're only
Mhm.
spending 7 minutes, that's going to leave me with lots of other questions, right? So,
Mhm.
what about you, Dr. Marshall? Can you respond to how long your visits? And do
Mhm.
you see a correlation there?
Yes, I spend an hour to an hour and a half with my patients, and and that's for whether it's a physical, whether it's follow up, if they want to sit and chit chat. And I have to say, the probably the first week that I signed up with concierge, I had a patient who had left my practice and came back when she heard we were concierge, and that first day, I diagnosed a PE just because I had the time
Wow.
to ask her all the questions. She had this chest pain. She had been ruled out for MI in the emergency room, but they hadn't checked her for a PE. And I took the time, asked about her family history and
Hmm.
all of this, and diagnosed it in the first week. So I find that having more time, I can ask more questions. I get a more thorough history, and I'm able to be a better diagnostician.
And Dr. Serdar, what about you?
I spend I would say hour and a half is for the annual, and then for a sick visit, probably closer to like 20 or 30 minutes. Not because I'm sort of watching the clock to get them out, but I think when they're sick, they just want to get seen
Mhm.
and get out of there. What I find is really helpful, to your point, Dr. Marshall, is like getting to the timepiece. They're able to there's a certain persona that walks into the doctor's office, and it's like I've actually physically seen them like take a breath and it just comes back down a level or two. And that when they're comfortable, like properly comfortable, is when I see them ask the real questions, you know?
Mhm.
So that's what makes you a better doctor is like A, they're going to give you more information, but B, things are more transparent, things are more easy. I mean, I don't want to give us less credit because I think we're good doctors, but it's not rocket science. Like, we just need to ask the question, but we just have the chance to ask the question and make them feel, oh, I'm actually going to sit here and listen. I'm not going to be like, okay, 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 next thing, which is unfortunately, I was guilty of that as a hospitalist. I was like, I have 25 people and they're all critically ill. And if I stay here more than the 20 minutes I have, I will never go home. Right.
Mhm.
So there's such a difference in how we practice. I think I hope that answered your question.
My son's actually a hospitalist in New Orleans. And yes, we've been there in the heat in the middle of the summer for 22 years. But yes,
It's a lot.
that's when they all come, all the tourists come. So, Dr. Dia, what is your situation? How long do you spend with patients? And do you think there's a correlation there?
Typically will give my health assessments an hour, and then my sick visits will be like anywhere from half an hour. Usually I book them half an hour to 45 minutes, just so I just put little gaps in my schedule so that I'm not like back to back to back to back all day. One of the things I will tell you guys that stressed me out a lot when I was at Kaiser was that I would get late because I would spend so much time with somebody and then I'd be like late for the next one, late for the next one, like, and that would just make me so anxious. So I make sure that my schedule is like nice and clear. I've got like maybe 5 or 6 patients a day that I see and that I give them plenty of time because the last thing I want to do is feel stressed. I want them to understand that this is a stress-free environment. And yeah, so I give them plenty of time. I give them about 45 minutes for a sick visit and about an hour, maybe even more for a health assessment.
All right. So we have several people that are still on the Zoom meeting with us. I wanted to open it up for questions. If you have questions and you just want to direct them to the whole panel or to an individual speaker, we'd encourage you to do that now. Anybody have questions for our presenters? And I know at least a couple of you have had experience in this realm, so you may want to offer your own insights as well. Dr. Baltazar, you have your hand up.
Hi, thanks again for the speakers. I enjoyed listening to you guys. We actually have a DPC. I'm your neighbor in Howard County. Um, and my husband and I, can you hear me? Because I can't tell.
Yes.
Okay.
Yes.
So we started a DPC fall 2024. And it's slowly growing. I actually don't see the patients. My husband sees the patients. He's internal medicine. We're both internal medicine, but our path was kind of different. I have an aesthetic medicine practice. And so we have our own space. Like we bought, when I started my practice, we have an office condo. So I just said, my husband wanted to start a primary care practice. I was like, well, I've got space. So he basically moved in. And so I see him all the time now. But anyway, so we started the practice like fall 2024, like I said, slowly growing. My question for you guys is like, given with regards to your membership, for those that are doing direct primary care, um, do you have patients that want to use their HSAs? And I'm specifically asking because with the One Big Beautiful Bill thing that now the IRS defines direct primary care as a practice that charges $150 for membership. So that puts a cap on what a single member can what you can charge a single member, or else if it's higher, then they can't use their HSA. So, I mean, that has affected us in terms of like, our pricing model. So I was just wondering like what it's been like for you guys, and how are you handling it with any patients that potentially want to join the practice or are members now and they say, I want to use my HSA. Thanks.
Anybody had an experience with that?
I've had patients use their HSA for their concierge fees. And so, but what I had to do is write a letter like, this particular patient had complex medical issues. And so I wrote a letter, sort of a like medical necessity, like this is the best way to manage her complex medical issues. And she was able to get reimbursed from her HSA for her concierge fees. But I don't know that she was able to, get reimbursed for the entire amount, but I know that she was able to get at least a portion of it reimbursed through her HSA.
Either the other two experienced this?
So my patients, I don't think they use their HSA for my fee. I've never been able, I've never, made that available. But I do provide super bills for everyone who wants them, and they can submit to their insurance company and get reimbursed for at least partially for their health assessment or whatever. A lot of my patients do that. Um, but I just provide that super bill for them.
I think the question was I had was because so if your membership for the way I understand it, the way the IRS defines this is that if your membership, if the practice charges 150, then the patient, no, they can't contribute to their HSA.
So I just learned today that there is going to be a resolution in MedChi's House of Delegates that's going to ask the American Medical Association to evaluate this, to look into it and see if regulatorily it can be addressed and be, solved, if you will. So that would be helpful. Obviously, that takes time.
Yeah.
But
No,
yeah.
No, I know, because I was like, I
You're
helped with
probably
that
part of that.
resolution. Yes,
I was
I
going to say,
am.
that's right.
Yeah.
So Dr. Kludenev is asking about covering for vacations. What do the three of you do? Dr. Marshall?
So I have two other concierge medicine partners, and so we just rotate call. Well, I take some of my calls, but we pretty much cover for each other. And because we have the phone system that can forward the calls, it's great. And one thing that I've found to be helpful is when we let my patients know that I'm going on vacation. I know patients don't like doctors to take vacations, but in this case, they're like, oh yeah, Dr. Marshall needs a vacation. We're not going to bother her, and so they defer to my partners that cover for me.
That's great.
I
What
was
is
writing
your
a little
experience?
private note. I write a little note like, hey guys, just wanted to let you know that I'm going on vacation for a week. I'll sometimes describe where I'm going, going on a bike trip with my husband to Switzerland. And I'm going to be available through the portal. I will be answering all portal questions for all of you. But Nadia and I, and there's another physician, Dina, we're three solo practitioners, and we sort of decided that we're going to cover for each other.
Oh, nice.
So,
Very cool. Dr. Serdar, any other
No,
aspect of
just
that
I'm
you want
so
to
lucky. I
address?
feel so lucky and happy to have found two other physicians who practice similar to mine. So it's been actually
Sure.
lovely. It's something they often ask on the discovery call. What if something happens to you? What if your child gets sick? I mean, and I just say, we have other physicians in the community that we have this relationship with. It seems reassuring.
So there's been a question asked about what percentage of your fees, if you're using something like Special Docs, goes to the concierge company, the platform.
Yeah. So I'll address that. So I did a little bit of research on the different fees. So one of them was MDVIP. They charge a lot. It's like 33 1/3%. And that's for the lifetime that you're with them. And so I did not go with them, but I went with Special Docs. So Special Docs does a different, they have a different approach in that they charge roughly about 22% of just the membership fees for the first 4 years. And then after that, it goes down to a flat 8%. And so I felt that was more reasonable. The amount of work that they do or they did to set this up for me, they did all the marketing, they did all the setting up the membership portals, they did, because we had a large panel of patients. We had it was probably like 12,000 patients that we sent notices to. We sent mailings to them. We sent emails, drip campaigns, like text messages. Like it was a massive marketing feat. And so for that reason, I needed a partner. If I was starting from scratch, maybe not so much, but also they helped anticipate they answered all the questions that I had, like what's going to happen when I go on, are the patients going to call me? Because they had done it so many times over, they knew the answers to all of our questions. There was this great degree of comfort that I have with them, and they have been an excellent, excellent partner. I highly recommend Special Docs. They've been great.
either of the others have an experience? Did you consider that?
Yeah,
Did
so I
you?
did consider special docs. I have friends in Virginia that have a practice, Ira Marate, and a group of them that have, there are three of them under special docs. And I did consider them, but I really, I felt like I was gonna try it on my own first and see how it goes. And if things didn't go smoothly, then I could always turn it around and have them involved in the project. But honestly, I have kind of figured out what I need to be doing, and it's been okay without anybody helping me, just kind of doing it on my own. It's hard. It's hard to be an office manager and know everything about your EMR and everything about billing and everything about, but I just feel like
Alexa, turn off main.
Sure. Well, there are certainly many companies that reach out to the medical society, and we've encouraged them to exhibit, you know, to advertise, et cetera. And but I think we were hesitant,
Alexa, turn
certainly.
off main.
Hello, we have, let me mute that person. So we were hesitant. We wanted to start this way. We wanted to hear your experience. Certainly, some of those companies would like to present to the physicians, but we wanted to start organically and because we knew that all three of your practices were very different and you were in different stages. We didn't want it to be nothing more than a sales opportunity for them. So we have time maybe for one last question. Anybody
I was
have
just
one
going to
last
say
one?
something really quickly, Susan. I did a lot of
Sure.
research on MDVIP. I find them, at the risk of sounding very blunt, I find them to be very predatory on physicians. And I find that their return on what they're like quote unquote like offering is just not good enough. And
I
so
agree.
I would never, I wouldn't
I
let someone
agree.
I care about go with them.
I agree.
Yeah.
Okay. Anybody
I
have one
wanted to
final question? Yes,
I wanted
Dr.
to
Marshall.
just say one last thing. I think someone said, Dr. Baltazar said you bought your real estate. I also own my real estate, which has allowed me to keep my rent, which is one of the biggest expenses, fixed at a mortgage. And so, if you are thinking about practicing for, more than 10 years, I do highly recommend that because all these leases, they have these, 3 or more% escalations every year. And so, consider if you can buy your space. I think that's been a great way to kind of control the costs as well.
That's great information and insight. We also have real estate companies that are interested in working with you. Well, we want to thank you, all three of you, for sharing your own personal experience, your journey with us this evening. I think it's very helpful as more and more physicians who frankly find the Maryland environment, the practice environment, untenable for them. We see a lot of physicians going over to Virginia to practice, but living in Maryland because the payer rates are different there. So we really congratulate you on finding these kinds of models that are working for you and your patients. I think that's so very important. So we would ask you, if you will, to let us know what you thought about the value of this program. We are, as I had mentioned, in the middle of a strategic plan, and we're trying to evaluate all of the resources and services that the Medical Society offers, and whether or not you found this engagement, this connection, this information very helpful to you, and whether or not, at the end of the day, because we're a membership organization, whether or not it made a difference in whether you're willing to renew your membership in MCMS and MedChi. So we really thank you to our speakers. Thank you to our attendees. We will make this recording available to other physicians through a link in eNews on Sunday. So don't be surprised if you have others reach out to you. Whether you want to be a mentor or not, you might end up being
I didn't
that
mean
way.
it in a rude way. I just meant I
No,
don't know enough
we
yet.
No, and matter of fact, you've now met other people who might be a resource to you.
Yeah.
So that's perfectly fine. Well, thank you so much for sharing your expertise with us. We appreciate being with you this evening. Thank you for your support and engagement with Montgomery County Medical Society, and we look forward to seeing you again next time. Thank you so much.
Thank you so much
Thank
for
you for
having me.
everything, Susan.
you.
Thank you for having
Thank
us,
you for
Susan.
Hannah.
Thank you.
All right.
Thank
Bye.
you. Thank you. Bye-bye.